Look at your hands right now. If your palm is red along the edges with a paler center, that has a medical name and it speaks directly about your liver. Today I'm going to show you the 7 signs the liver leaves on the skin when it is under stress, how to identify each one, and what to do with that information. Sign number 7. Diffuse brownish spots on the neck, armpits, and skin folds. These spots have a medical name, hepatic hyperpigmentation. They look like age spots, but have 3 important differences. First, they appear in areas of little sun exposure, neck, armpits, skin folds, while typical age spots concentrate on the backs of the hands and the face. Second, they are diffuse, with imprecise borders and a reticular pattern, like a fine mesh over the skin. Third, they appear or worsen over months, not years. The mechanism: a compromised liver cannot adequately metabolize circulating estrogens. The excess stimulates melanocytes, pigment-producing cells, generating excessive pigment deposits. Fat-soluble toxins the liver should eliminate accumulate in skin cell membranes and intensify that production further. Frank was 69 years old, a retired accountant from Sacramento, with brownish spots on his neck for 2 years. 2 dermatologists said they were age spots. A general practitioner ordered a full hepatic panel and found ALT of 78, AST of 64, GGT of 91, and grade 2 hepatic steatosis, never diagnosed, with no gastrointestinal symptoms. The spots had been communicating hepatic dysfunction for 2 years while being treated as a cosmetic problem. What to do? Recently appeared brownish spots on the neck, armpits, or skin folds require ALT, AST, GGT, total bilirubin, and alkaline phosphatase alongside any dermatological evaluation. Do not accept an age spot diagnosis without ruling out a hepatic cause. Sign number 6. Intense itching with no visible lesion, worse at night, not improved by antihistamines. The medical name is cholestatic pruritus, and it is the most overlooked and most misdiagnosed hepatic skin sign. When the liver cannot adequately eliminate bile salts through bile, they accumulate in the bloodstream and deposit in the skin, directly stimulating specific nerve endings, neurons with TGR5 and MSRGPRX4 receptors. The result is itching with no visible lesion, no redness, no hives. 4 features distinguish it: worsens at night and with heat, concentrates in the limbs, especially palms and soles, not the face, does not respond to any conventional antihistamine, and progressively worsens without hepatic treatment. Margaret was 67 years old, a retired teacher from Phoenix, who spent 3 years with dermatologists trying to treat intense itching with no visible lesion. 4 antihistamines, 2 topical corticosteroids. Nothing worked. When the general practitioner ordered the hepatic panel, GGT was 94 and the ultrasound showed diffuse steatosis. Targeted hepatic treatment reduced the itching by 60% in 6 weeks. What to do? Chronic itching with no visible lesion, worse at night, resistant to antihistamines, requires total and fractional bilirubin, GGT, alkaline phosphatase, and serum bile acids. Do not accept idiopathic dermatitis as a final diagnosis without ruling out the liver. Sign number 5. Visibly dilated veins around the navel, caput medusae. This is the most serious sign on the list. Caput medusae is the appearance of bluish, dilated, tortuous veins around the navel, radiating outward across the abdomen. The mechanism: when the liver develops cirrhosis, vascular resistance inside the organ increases, raising pressure in the portal system. Portal hypertension. That pressure forces blood to find alternative routes, including the periumbilical veins, which are normally collapsed and invisible. Under elevated pressure, they dilate and appear under the abdominal skin as bluish cords, sometimes pulsating. Unlike the other 6 signs on this list, which can appear in still reversible hepatic dysfunction, caput medusae indicates established structural damage. It is not an early warning sign. It is an urgent sign. Richard was 72 years old, a retired factory worker from Cleveland, who noticed strange veins forming around his navel over several months. His family thought it was just belly fat. When he went to the emergency room for another complaint, the ultrasound confirmed compensated cirrhosis with portal hypertension. The sign had been visible for months while being ignored. What to do? Any visibly dilated vein around the navel requires urgent medical attention, not an elective appointment weeks away. Go to an urgent care clinic or emergency room. This sign needs immediate evaluation by a hepatologist or gastroenterologist. Tell me in the comments where you are watching from right now. Write the name of your city, and if you are not yet subscribed, click the button and turn on the bell. The next video may be even more important for you. Sign number 4. Palmar erythema. Intense redness on the edges of the palms, with a paler center. Hepatic palmar erythema has an unmistakable pattern, intense redness on the thenar and hypothenar eminences, the fleshy pads at the base of the thumb and little finger, while the center of the palm remains relatively pale. This frame erythema is bilateral, worsens with heat and alcohol. Diagnostic test. Press the red area with your finger. It blanches completely and returns to red immediately when pressure is released. Active vasodilation confirmed, not pigmentation. The mechanism. A compromised liver cannot adequately inactivate circulating estradiol. Excess estrogen stimulates vascular receptors in the palms, a region with a high density of these receptors, generating persistent local vasodilation. Substance P and nitric oxide also participate in this process. How to differentiate from naturally red hands. Hands that are warm and red by predisposition tend to be diffusely red across the entire palm. Hepatic palmar erythema has that specific pattern of red borders with a paler center, and it is new or progressive, not a long-standing characteristic at the same intensity. It can also occur in pregnancy, rheumatoid arthritis, and hypothyroidism. Always evaluate in full clinical context. In a person over 60 without those other conditions, progressive bilateral palmar erythema is a hepatic sign until proven otherwise. Patricia was 65 years old, a retired cook from Atlanta who had always had reddish hands. Her husband noticed that over the past 2 years, the edges had become markedly more intense, especially after a hot shower. The physician identified the hepatic pattern, ordered tests, and found non-alcoholic steatohepatitis with active inflammation, the form with the greatest risk of progressing to cirrhosis. What to do? Bilateral palmar erythema with red borders and a paler center appearing recently or worsening progressively requires AST, ALT, GGT, alkaline phosphatase, total bilirubin, and serum albumin. Sign number 3. Spider angiomas, small red dots with threads radiating outward on the chest, neck, and arms. Spider angiomas are so characteristic of liver disease that when more than 5 are present, they form one of the criteria of the Child-Pugh score, the primary severity score for hepatic insufficiency worldwide. Visually, a central reddish, slightly raised point from which fine vessels radiate in all directions. Diagnostic test, press the center with your finger. The lesion empties completely, becomes totally invisible, and returns to red immediately when pressure is released, as blood flows back through the central vessel. That centrifugal filling is exclusive to spider angiomas and distinguishes them from petechiae, which do not empty with pressure. The distribution is specific. Face, neck, prosternal area, shoulders, and forearms, rarely below the navel. The mechanism is the same as palmar erythema. Excess unmetabolized estrogens stimulating new vessel formation and dilation. A healthy adult can have up to 5 isolated spider angiomas without pathological significance. What is concerning? More than 5, especially in men. New ones appearing over weeks to months, combination with other signs on this list. A study in the British Journal of Dermatology demonstrated a direct correlation between the number of spider angiomas and the degree of hepatic dysfunction by Child-Pugh. Class A averaged 3.2, Class B 7.4, Class C 12.6. More spiders, more severe the dysfunction. Richard Sr. was 68 years old, a retired accountant from Cleveland who developed 3 new spider angiomas on his chest over 18 months. The dermatologist suggested cosmetic cauterization. The general practitioner first ordered the hepatic profile, ALT, at 94, GGT at 118, and diagnosed fatty hepatitis with active inflammation. The cauterization would have eliminated the sign while ignoring the disease. What to do? More than 5 spider angiomas, or new ones appearing in the last 12 months on the chest and arms, requires complete hepatic evaluation before any cosmetic procedure. Sign number 2, subtle jaundice, yellowing of the whites of the eyes, weeks or months before the skin changes. The sclera, the white of the eye, is the structure with the greatest affinity for bilirubin deposits due to its elastin-rich composition. That is why jaundice begins in the eyes. Scleral jaundice is already visible when total bilirubin exceeds 2.5 mg/dl. Skin jaundice only appears above 3 to 4 mg/dl. This creates a diagnostic window, yellow eyes with completely normal skin, which can last weeks or months. Most people do not regularly examine the whites of their own eyes, and when they do so under incandescent artificial light that completely masks the yellowing. There are 3 types of jaundice with different mechanisms: prehepatic, hepatic, and posthepatic. And distinguishing them requires fractionated bilirubin in the lab, but the visual sign is the same in all 3 and all require urgent investigation. How to observe correctly, always under natural light, near a window. Take a photo with your phone in daylight and examine carefully. Normal scleral color is pure white or slightly cool-toned. Any yellowish, cream, or golden tint is abnormal. Patricia Sr. was 71 years old, a retired woman from Atlanta, photographed by her grandchildren outdoors. Her son-in-law, a nurse, noticed in the daylight photos that the whites of her eyes were slightly yellow. Her skin was completely normal. Tests revealed total bilirubin of 3.2 mg/dl with predominantly direct bilirubin. Biliary obstruction from gallstones with early hepatic repercussion, treatable when identified early. The diagnosis happened because someone knew what to look for in a photograph. What to do? Any yellowing of the eyes, however subtle, requires urgent medical evaluation with total and fractionated bilirubin, ALT, AST, alkaline phosphatase, and GGT. Do not wait for the skin to change color. Sign number 1, Terry's nails, white or opaque nails with a narrow pink band at the tip. Terry's nails are the most underestimated sign on this list and the one most frequently confused with calcium deficiency. Richard Terry described the pattern in 1954, observing patients with cirrhosis. What to observe precisely? The nail plate becomes completely white or dull across its entire surface, except for a narrow pink or slightly reddish band at the distal end, the distal erythematous band, between 1 and 3 millimeters wide. The lunula disappears. The surface loses its normal pearlescent shine and becomes matte. The mechanism: the compromised liver synthesizes less albumin. With albumin below 3.5 g/dl, the tissues surrounding the nail bed become edematous, compressing the capillaries and making the nail plate white. The pink band persists at the tip where edema is lesser and capillary compression is lower. Reduced hepatic production of VEGF, vascular endothelial growth factor, also contributes to capillary rarefaction in the nail bed. Terry's nails can also appear in heart failure and severe diabetes beyond liver disease. But in a person over 60 with low albumin, the predictive value for hepatic dysfunction is clinically relevant. A review in the Journal of the American Academy of Dermatology analyzed 117 patients with Terry's nails. 68% had confirmed liver disease, with cirrhosis being the most frequent. Patricia's grandmother was 74 years old, a retired farm worker from Phoenix who came to a consultation for ugly nails that are turning white and dull over 2 years. Her husband described a pink band at the tip. It looks like the tip is bleeding from underneath. The dermatologist recognized the Terry's pattern, ordered serum albumin 2.9 gdl and full hepatic profile, ALT of 112, GGT of 143. Diagnosis: compensated hepatic cirrhosis from alcoholic liver disease the patient had never mentioned. The nails said what she did not say. What to do? Nails that changed in the last few months, whiter, more opaque, with a narrow pink band at the tip, require serum albumin, ALT, AST, GGT, total bilirubin, and alkaline phosphatase. Do not take calcium. Investigate the liver. Before the summary, one fact that changes the perspective of everything said here. A study in the Journal of Hepatology 2022, with data from more than 180,000 adults in 32 countries, estimated that non-alcoholic fatty liver disease affects between 32 and 46% of adults over 60, and that in 73% of cases with established hepatic dysfunction, cutaneous signs were present at least 18 months before the formal diagnosis. 18 months of visible signs ignored or explained as normal aging. The tests cited below are simple, covered by Medicare and most insurance plans, and can reveal what the skin was already trying to communicate months ago. Summary of the 7 signs to check right now. Diffuse brownish spots on neck, armpits, and skin folds. Hepatic hyperpigmentation. Order ALT, AST, GGT, total bilirubin, and alkaline phosphatase. Chronic itching with no visible lesion, worse at night, resistant to antihistamines. Cholestatic pruritus, order fractionated bilirubin, GGT, and bile acids. Dilated veins around the navel. Caput medusae. Immediate urgent medical attention. Red borders on the palms with a paler center. Palmar erythema. Order full hepatic panel. Small red dots with radiating threads, more than 5 on chest and arms. Spider angiomas. Investigate before cauterizing. Yellowing of the whites of the eyes under natural light. Early scleral jaundice. Urgent evaluation with bilirubin. White or opaque nails with a pink band at the tip. Terry's nails. Order albumin and hepatic function. 1 isolated sign. Request the tests. 2 or more signs at the same time. Urgent hepatic evaluation. Action plan for the next 7 days. Day 1. Examine your hands in natural light. Palms, edges, nails. Take a reference photo. Day 2. Examine your eyes in a photo taken in daylight. Day 3. Examine your chest, forearms, and neck. Do the pressure test on any suspicious red lesion. Day 4. Check around your navel in the mirror. Day 5. Bring your observations to your doctor and request ALT, AST, GGT, alkaline phosphatase, total and fractionated bilirubin, serum albumin, covered by Medicare. Day 6. If any test is abnormal, request a complete abdominal ultrasound. Day 7. With results in hand, schedule a follow-up with your primary care physician or hepatologist. My friend, the liver does not speak with words. It speaks with the skin. You have just learned the language it uses. Examine your body. Examine your nails. Examine your eyes. Get the tests done. Early diagnosis is the difference between liver disease that can be reversed and liver disease that can no longer be reversed. God bless you and give you much health until next time.